posterity. Hope that works for everybody. If not, you know what to do. Greetings and welcome to our call here today. And our usual process is, and this is more for Arlington folks, just to give you a kind of an overlay of what's happening. I mentioned this to you previously. We just do a couple of updates, some new news, and kind of check in from some of the work groups, and then we'll dive into your sort of presentation and discussion of what's happening in Arlington and some of the other stuff we talked about on the call the other day. So we'll dive into that briefly. Most of the people on the, actually virtually all the people on this call have been sort of regulars, or most people have been pretty regular for the last couple of years. So it's a good group of folks who are pretty familiar with each other, but are shy to put their cameras on. So we'll encourage them. I always forget about the extra points when you turn your camera on, to welcome our guests here and see a face and put a face and a name together. So if you got a camera, go ahead and be bold and put it up there. So we did send out, Amanda did send out the agenda earlier today, and essentially, I'll put it up there really quickly to show, see what we got here. It's the standard agenda where some new announcements. You all are receiving Amanda's weekly roundups. Thank you for continuing to do that. Brian or Eric or Adam, did you guys look at these and think about any commentary, or Amanda, we want to mention on these that were particularly relevant?
I can provide a little bit.
Oh, that's great. Thanks, Brian.
The first item, the new healthcare ecosystem will depend on FHIR APIs, but are they secure? Secure. This is just a repeat of the article that has been kicking around for the last couple of weeks about FHIR security. And it wasn't a question of whether or not the FHIR APIs were secure, or even the EHR implementations of FHIR secure, but whether or not the apps that have been developed and other associated patient information aggregators were implementing with all of the appropriate security in place. And the answer, based on some testing, was, well, no, not really. So, they better get their act together and clean up their implementations. The second one would be ho-hum. I mean, HL7 and SNOMED are renewing their ongoing collaboration work, except that, they've been doing this for 7 years, and the collaboration has produced some good results, I think, in terms of ensuring that SNOMED codes are integrated in with the EHR implementations, are integrated in with FHIR, et cetera. And we certainly have been making good use of both SNOMED and ICD-10 and LOINC codes within the Gravity project. So I guess, yay team.
Thanks, Brian. The other item here that Chris Albronte had shared with us, and I don't think Chris is going to be able to join us today. Both she and Jim St. Clair are either at meetings or at travel at the moment in time. So there is an all-in, which is part of the data across sectors for health and part of the Robert Wood Johnson Foundation supported efforts. That national meeting is coming up next week. We looked at the agenda there a while ago. There's some real interesting things on there. It's a lot of things going on across the country. Chris had offered up, I think they are still available, a few passes for people who wanted to join. I think a few people raised their hand. If you have interest in participating in, or sort of attending some of the all-in, I think Chris had a couple available passes from the work she's now doing at the Network for Public Health Law. So if you have interest, put a note in the chat, and Amanda will capture that, and we'll check back with with Chris. I was looking at Anita on the camera there. We'll check back with Chris and see if there's still availability. And so go ahead and just put it in the chat. There's been interest from All-In and Dash to share some of the consent work that we're doing, the scan, and they're looking for different opportunities. the agenda is pretty set, but we're looking for a couple of different opportunities to share that during the event or before or after the event, something like that. So we should have some opportunity to do that. So go ahead and do that if you have interest. And for those who may not be aware, we have we document these notes. We document these meetings with notes and the recordings. You'll see a link there to the weekly Unify notes. And Amanda's done a great job to sort of organize those for us. So if there are topics that you may have missed that are of interest to you, and there's a whole bunch of them that have gone on for a while, feel free to jump into there. If you're not on the mailing list, please on the weekly notes, just email Amanda as well. And folks from Arlington may or may not be. If you want to join, just send her your email in the chat as well, and she'll add it to you. She does a great job sort of scanning. We felt like we wanted to scan what was going on out there. Everybody's so darn busy. It's really easy to miss some sort of interesting things that are happening. So it's a really nice overview and recap of stuff like, oh my God, that's happening. Who knew? So that's pretty wonderful. So just a couple minutes we're going to spend on any updates, any of the work group updates, and then on the scan. So and then I'll turn it over to Adam to talk about that. Brian, Eric, any things going on in the work groups that are useful to share quickly at the moment?
Well, if you think it's appropriate, I can share the 2022 planning, but I haven't had a chance to talk to you about it yet.
Yeah.
I yield to you on whether or not it's appropriate to talk about that this week or next.
Probably makes sense to talk about that next week if we have a chance to look at it and get our feet on the ground. But that is looking at, we'll be looking at that for the work group process, right? And we're looking at inviting more people into that process.
Right.
Great. Eric, anything new on the work you're focused on?
I believe that some of the members of the child welfare ontology group are, within the ontology work group are working on that. They might have something to update, but the HMIS ontology has been made version 1 release, and the core ontology, Brian, we haven't started anything on that, have we? Or do you have any updates on the core ontology work?
I have some stuff, but I haven't had a chance to upload it yet to GitHub to share it. And until we do that and I get review feedback, it's probably a little premature for me to, thump my chest and say, yes, I've got something.
Okay. And I'm in communication with Dr. Renner at MITRE Corp about OWL and the use of that in NEAM in the meta model. And we're actually trying to figure out a solution here. We're running into some technical hurdles, and I'll update those to the team next week once I have my head around what my response will be on that one. But now that's our update. Unless anybody has any ontology updates that they're working on independently, because we're kind of a decentralized group.
Great, thanks, Eric. Any other updates from folks that are be useful to share at the moment? If not, Adam, can you give us a update folks on where we're at with?
I will. Can you give me, I want to show the piece of the report. If you give me control.
I'm in your way. There you go.
I got it. Okay.
I should have it now.
Okay. So this will stop other people's screen sharing. Do you want to continue? Yes.
Yep.
Okay. So can everybody see this?
Yep.
Okay, great. So remember, those of you who have participated in putting this report together, first, every week I say it, I'm going to say it again. Thank you. We couldn't have done it without you. And the piece, the overall product really shows the expertise that you all brought to the table. And so those of you who participated or just listened to some updates know that a couple weeks ago, we put a stop to input because it had to stop at some point. We had to put this out. And I asked people, unless there was some glaring error, just to stop providing input. I say that because just a few days ago, we got some input from our funder, from our program officer, and we permitted her to submit it. It's kind of a joke. We had hoped we were finished, but she had some honestly very good and constructive input that's worth putting in on its merits, and not to mention that it would be, is the word dumb, to tell a funder that nah, you're too late. So we are the piece, the product that we thought we were done. The bottom line is that it's almost done. It's probably literally tomorrow, but you've heard this before. I'm not going to tell you again. It's imminent. And the piece, the entreaty I want to put out, because is for all, and we discussed this before, we're going to ask for your help, to put it out in your own lists, to write blogs as appropriate. I'm happy to help with the planning of whatever, especially the writing and editing if anybody wants it, for your newsletter, for posting on your website, whatever. The caveat that I want to ask, I want to put out is this, that the timetable for asking you to do that, for doing that, is going to be tighter than we hoped it would be, because holidays are coming up. So after we finish this thing for real, and submit it to the funder, to Robert Wood Johnson, Thanksgiving is going to be coming up, and then Christmas is going to be coming up. So there will be some windows. We can absolutely always put it out. It'll still be a new product. We can put it out in the new year. But I just want to get this on your radar. If you can think about what can you do in the next few weeks to get this out into the world. The other thing worth saying about this, and then I'm going to show you just a little piece of this. The other thing worth saying about the funder, our program officer, is that again, she had really constructive criticism and input. So I don't want to make this sound one-sided, but her bottom line was impressive, really impressive. So that's pretty good stuff. That's really great to hear after so much work has been put into it. And full circle, I mean, truly, we could not have done this without the expertise that you all brought to the table. So thank you again. So the one thing that I do want to so this is what it looks like for those who haven't seen it yet. And a long table of contents. And I wrote an executive summary that's on it now. Daniel, we can probably, with watermarks so that it's not published, we could probably put this up for people to at least take a look at it tomorrow or day after tomorrow, no?
Yeah.
So we will do that, okay? And then the piece that I want to show you in the executive summary, and it's also fleshed out in the, where is it? No, I missed it. And it's fleshed out in the main report, is, here we go, is voices from the community. This is, so Daniel and I interviewed, and thanks to Paul Meisner, a handful of people from the Bronx who are with the CRRB there, the review board, about our report, about the issues in it, and so forth. And I'm highlighting it here because for all of our edification, I think it's really interesting that when you actually listen to the people who are affected by the work that we want to do, that we're proselytizing and implementing, their priorities are sometimes pretty different. Our report really looks at technology and legalities, and we talk about culture and trust and all of that. But when they weigh in, they want to talk very much about trust. They want to talk, see these, you can read these quotes. It should be about relationality, relationality, relationality. Data is not going to matter in the absence of remediating harm and shaping relationships. Just by way of example, what they're talking about. So we want to, and we believe that it is going to be far better when we automate this process, right? Computable data. what they want to know is, wait a minute, if I got to do that, can I get some paper to take home? Because this isn't just going to be about me. My wife wants to weigh in on this. If I provide consent to share this information, it's going to affect, these two people who live in my household. I want to go discuss it with them. So there are some just really insightful and interesting observations from them that I think it's incumbent on us to factor into our work and our thinking. And so when you do look at it, once we post it or once we publish it, please take a look here, because I think this is a real keeper and provides important fodder for us as we go forward. And that's it. That's our update. Thanks for doing everything you've done. And now we were very grateful for your help getting this out into the world.
Hey, Adam,
Very soon.
Adam, just for clarification, the process or the sequence is you put the wrapper on this and then submit it maybe tomorrow to Robert Wood Johnson, and then they review it for a certain period of time, send back for any, errors or corrections or suggestions or whatever.
No, I think they've given us their suggestions. I think Daniel, correct me if I'm wrong, but I think that we'll as soon as we've written our blog and gotten posted and all that stuff, I would think by next week we will be formally publishing. Daniel,
Okay.
does that sound right to you?
Yeah, absolutely. So Hillary Heichman, many of you may know her from RWJF, is an exemplary program officer.
She really is.
Having worked with a lot of foundations, and she provided very direct and very useful feedback. So, which is great. She values the work, and so we've taken that to heart. And we're obviously want to make resonant with them. And I think I shared with folks last week that RWJF has put out their commission report. And I just mentioned it for a second, and we can send out the links to it as well. I'll share those put it in the chat when we get started here. But they've announced, they've just finished, I don't know, maybe a year's worth of work looking at where they're headed next as a foundation, sort of, in my words, sort of beyond culture of health. What's the next turn of their strategy? And it's pretty comprehensive, but it's very much rooted in equity, data sharing, but equitable data sharing. And so, that's a key theme. And they have, as you'll be interested in reading, they in addition to the commission report, which is excellent, and summarization of 4 separate white papers on kind of the who, what, why, and where, or when, or whatever. Very detailed white papers on many of the relevant topics. It's about 160 pages long. And I was fortunate enough to be asked to participate in that effort last summer. And so we got mentioned in there as well, which is always nice to see yourself. It's an amazing process they went through with a lot of people. And it's a great document, very very comprehensive and very informative about what we're doing. And the exciting part for me is that I think that RWJF is really now moving more into some of the consideration of the technical and the technological issues as well. That has often been, in my experience, an area that foundations have shied away from, I might say, or it hasn't been part of their direct work. And here you can see, as they talk about FHIR and they talk about interoperability, they talk about those things as in the guts of the report, as well as consent and our work in that as well. So that's very encouraging. In addition to the note that they've now earmarked $50 million for the work going forward in 3 tranches of work. So like a lot of stuff RWJF does, when they move in a direction, they're pretty comprehensive about it. So they will be starting up a number of initiatives. I don't know the timing of it. I know that this work is of great interest to them, and it's in the report. And as we know, it's urgently important and critical for data sharing anywhere. And I think everyone we've spoken to about it would sort of readily agree on that. So I'll put the link in there. It's really worthwhile reading through it and getting familiar with it. And we certainly hope that this scan report is really just the beginning of our efforts with them, and that we sort of are able to actually bring this to fruition and some real serious work going forward.
Adam,
So, yeah, go ahead. Yeah.
I'm sorry, Adam, I have a quick process question because
Sure.
you said that you need some feedback from the group here and you need it before the holidays, but then.
No, I don't need feedback.
Oh,
I
okay.
apologize if that's the impression I left. No, we're asking for your help to disseminate this thing.
Oh, it's the dissemination piece. Okay.
Yeah.
Okay.
No more feedback unless you're our funder.
Well, you said it was almost done because, you know, you'd gotten this feedback from the funder and then now.
No, we're good.
I was confused about.
Hey, I apologize if I left it confused. No, we're done.
Great.
The
Fantastic.
designer is just inputting some, I turned the feedback into some changes. The designer is putting them into the document and we should be good to go starting tomorrow. And we can, once we have that, we'll put a watermarked copy you know, in SharePoint or somewhere so that you guys can take a look at it. And feel free internally, obviously you can't move it out, but if you want to use that for your planning purposes, if you do want to write a blog or use a newsletter or send it out, whatever, you can certainly use it for those purposes.
And Adam, when it is officially done, you're going to notify us and then provide us with a link or something to like include in a blog that the
Absolutely.
reader could go to download the report, maybe submit their email or something like that, and then a download.
Absolutely. And we'll also give you hashtags and, you know, other communications pieces to make that job a bit easier.
Great.
We've chopped it up into two, both a sort of an executive summary with the table of contents and basic recommendations, about 5 or 6 pages, I think, somewhere around there, and the participating organizations. So people are recognizing that, and that's a very consumable document. It's got the recommendations in it. It's got the sort of key thoughts in there, and then of course the whole thing is about 75, 80 pages long. So I think it probably, we'll send everybody here either a link or just the actual copy for your reading pleasure. But then what we'll do is we'll post it with that link. I think, and to your point, we ask people for their you know, their email to get at it. And so next week, I think what we'll do, if we don't do it before, is we'll go over some of that stuff. We'll have a kind of a worksheet for folks or some recommendations on how to do that.
For sure.
Hopefully, we'll be in a good position to sort of push that out and move forward with that.
Great.
And actually, if there's anybody who's good at the social media, because I'm okay, but I'm no pro. You know, with the LinkedIn and Twitter, if anybody wants to volunteer to work with me to develop some of that, great. If not, don't sweat it. But if so, graciously accept the help.
And Adam, I'm okay, and I'd be happy to help to the extent I can. But of course, my colleagues at Point of Care Partners are good at that. So, you know, we'll help out any way that we can.
Appreciate it.
All right. Without further ado, I want to introduce our colleagues from Arlington County, Virginia. We asked them to speak today for a couple of reasons. One is Arlington has been in the forefront of data sharing and interoperability for as long as I can remember. They've been working in that space very consistently for a while. And, you know, many of the conversations we've had on this forum and the other Let's Get Technical forum over the last couple of years have been pretty sort of technically focused, which is great. And it certainly serves an important purpose. And I felt like it would be useful to hear, as though many of you are already directly involved with, you know, sort of direct service delivery and management and those kinds of things. But it would be great to hear kind of what the process is like, what the challenges are, what the successes are like. And this was really prompted in part by when I learned that they had condensed their enrollment across all of their programs down to 2 pages. And then the light went off for me because we're talking about, you know, trying to provide an integrated sort of consent management tool or interface. And the thought about that really got me thinking about how do you do that kind of consolidated work with people coming in with multiple needs and needs for different services. And so I've known folks from Arlington for a while, and they're actually we're actually working with them on our, had the good fortune of, they're one of the counties we're working with to share the interoperability training program funded by Kresge Foundation. And so we had a chance to kind of share some of that stuff. And it just really made sense to hear from them today. And I've asked them to present a few things, just to give us a context, background, what they're doing, how they got to where they are. And of course, then, like always, to have an opportunity to talk and ask questions, because they're the folks who are actually implementing this stuff, or being tasked to implement these things, which sometimes are obviously a lot easier on paper than in actual working with real people in real organizations to do the work there. So, so we have Director Anita Freeman. Wave at us there. Hi, Anita, thanks for joining us. Michael Dharma Arwin, who's the DHS Quality Manager, and Jan Longman, who's Compliance Officer. And so I'm not sure, Michael, if you are presenting. I think I gave you I can give it to everybody else as well. But let me turn it over to you and take it away. And we may interrupt along the way, and certainly if there's questions, everyone feel free to put them in the chat or just raise your hand. And away we go. Thanks again for taking the time today.
And before we get into the logistics of the ROI, Anita, would you like to say a couple of words about just the nature of DHS and the structure of our organization?
Sure. Well, we're in Arlington, Virginia, the state that unfortunately had a terrible election yesterday. But aside from that, we are a small 25 square miles, highly densely populated county, not a city, a county next to Washington, D.C. We are an integrated Department of Human Services. We only have one entity that's locally funded through the government with and also federal and state funding, where we provide comprehensive health and human services to around 30,000 people in the county, which is a county of 230,000 inhabitants. The area median income in Arlington is very high. It's $125,000 per year for a household of 4. The folks that we serve typically are at about 30% of that area median income, or $35,000 for a family of 4. We have everything from birth to death, prenatal care, to issuing death certificates. We have all of the public health, including the coronavirus vaccination response, housing. We don't have a public housing authority. We have a voucher system that's federal, and a local housing grants program, excuse me, child welfare, comprehensive behavioral health services for older adults and for people with disabilities. So we have about 700 employees and a budget of about $150 million. Go ahead, Michael Dharma.
So as Anita mentioned, DHS has many programs, over 100, but we're also part of a very diverse network of social safety net services, including those provided by our school system and a wide variety of nonprofits, affordable housing providers, low-cost primary care clinics, food banks, et cetera. Bridges Without Poverty was an initiative we started several years ago to try to develop a shared understanding of client needs and barriers to care across our complex system. We started this initiative by offering training for about 200 DHS staff and nonprofit staff on what those barriers are, how difficult it can be to navigate a safety net system, the challenges that paperwork can present, the challenges of dealing with multiple case managers, et cetera. And based on that training, each partner looked at their own processes to see what improvements they could make and streamline access for clients. We also looked as a group for improvements that could be made at a system level. We looked at ways to improve the referral process. We developed a comprehensive public directory of DHS services that partners as well as the public could access. We opened up a social service resource wiki that all DHS and nonprofit staff could access so that we all had a shared understanding of resources in the community. And one element from this plan was the need for a single multi-party release of information, one form the client could initiate with any provider to share information across whatever partners they chose. As far as why that ROI was such an important part of our process, one was it was key to improving access. When a client had an emergent need. They needed food from the food bank. We didn't want the lack of an in-person signature to be a barrier to them getting that service. We also wanted to make sure that we had an opportunity to discuss potential needs with the client up front. And by going through that release of information and saying, you know, if you need help with food, here are providers who can help you. If you need help with housing, here are some resources. It was a way of helping the client and the case manager have that conversation. It was also a tool for reducing paperwork. When we have release of information that covers one organization, each family member needs to fill out one release per organization they're being referred to. So if you have a family of 5 people being referred to 5 services, that's 25 release of information forms. That's a slow and burdensome process, whether it's being done at intake or any other part of the continuum. So we wanted to reduce that burden for clients. And we wanted to reduce delays. When any of our providers in the system got a form they hadn't seen before, say the food bank has their own release form and they send it to us, we have to have that reviewed by our compliance officer or by legal. If it's not filled out correctly, if it's missing a signature or a check mark, we have to go back and forth. And that's delaying services when the client is in need. Information sharing across the system. So apart from the logistics of consent, there are other barriers to information sharing across providers. There could be different interpretations of what information could or couldn't be shared. Each bureau or each provider might have a different reading of HIPAA or other laws. There could be different understandings of how to securely exchange information. One provider might think that it was appropriate to, you know, do an email with a password protection. Another one might do encryption that another one might not be able to read. So there were some logistical barriers. There were different interpretations of what makes a release valid. And the process of developing a single form that everybody was familiar with and anybody could initiate gave us a chance to establish consistent expectations across the system. And finally, laws. DHS, our own organization, has multiple privacy laws in effect, including HIPAA for health information, 42 CFR for substance use information, and additional guidelines for other types of information like social services. The school was a key partner, so FERPA was also a regulation we wanted to take into account. So meeting the requirements of all these laws was important to us. I'll turn it over to Jan now to tell you a little bit more about what that process involved.
Right. So, you know, when we were developing this shared form, one of the most important things is we did it as a base, you know, we based it on our mission, which was to improve access for our clients who needed services. So whenever we got hung up with issues, we went back to our mission. Why are we doing this? How do we remove the barrier? We brought legal to the table, and the first thing we had to do was research state laws, because even though there are all kinds of federal regulations like HIPAA and FERPA and VAWA and, you know, all the acronyms we can come up with, each state also has its own privacy regulations. So making sure that we were on board with that. Fortunately for us, the state of Virginia had done a similar shared release of information about 5 years earlier for state agencies. So we had legal precedent to take to our county attorney and to share with the attorneys for our community partners to say, see, they've already done this research, you know, here's some precedent to rely upon as you make your decisions whether or not you want to participate in this program. You know, as Michael Darmus said, there are lots of different variations of the interpretation of the regulations. You know, oftentimes, you know, the regulation will say that you may share information, and depending on the privacy officer or the attorney for the organization, they may or may not. So it's trying to get everybody on board on a baseline. And that was one of the reasons why we really championed this consent at front doors. You don't get into the, you know, this organization shares more than this organization. We have consent, and that just, you know, resolves the problem.
Jan, can I ask you a question quick?
Sure.
One of the things is, I just wanted to clarify, did you find in that review that different counties across the state were interpreting it differently, the state law differently?
No, absolutely.
They were. I mentioned that because the work we had done in California, I was really surprised to hear that you know, the different privacy officers would interpret the state interpretation differently, which I found confounding in a way.
Oh, it's absolutely. I am a certified privacy officer by the Healthcare Compliance Association. That is rare that you have folks who are privacy officers for organizations who are either attorneys or certified. There are often folks who've read the law once and got training, and, you know, the training they know is the training they stick to.
Yeah.
so, you know, they're not always keeping up on the changes, the nuances of the regulations, and it often depends on how risk averse the organization is.
Mhm.
You know, we are certainly as risk averse as any other county, but we are always going to put client need in front of, you know, legality. You know, so we err on the side of may. Other organizations don't do that. So it's certainly a challenge. We've done a lot of education. And that's why, you know, having that legal precedent, and Virginia is not the only state to do that shared work among state agencies.
Mhm.
Having that legal precedent certainly helped me have conversations with other privacy officers of organizations and with their legal team, and even our own legal team, to be honest, to get them on board with this. So there is a lot of face-to-face time, you know, getting people, to the table, making sure that they're heard. And there are some people who didn't come to didn't leave with embracing this shared release. We had a really hard time getting the school system on board. We had a very hard time getting our domestic violence programs to use this form. What we did get to, and we consider that a victory, is they would accept it from other organizations. So while the family may have to re-sign their own form that their attorney said they have to use, they'd at least accept ours, which certainly reduced barriers as we were doing referrals. But, you know, so respecting folks' current processes, where they currently are, what their risk aversion is. We did face-to-face training. We created training videos. We helped a couple of vendors create videos, not only for their staff, but for their clients, you know, helping them understand the consent process.
Right.
Because oftentimes when clients are coming in, they don't understand the consent process. They're willing to sign anything you put in front of them for them to be, you know, to get the service that they need, but making sure they understand what they're signing, that it does have ramifications, that the services they're requesting aren't contingent on them signing this consent. And as Michael Dharma said, also showing them the breadth of services that are out there. It's like, you know, let's deal with this one need that you have right now. You know, let's get you to the food bank, get the food you need, but then let's talk about how these other programs can wrap around you and improve services. And this form has been a tool to do that.
Mhm.
And we certainly also ran into technical issues. Many of our organizations are small mom and pop organizations. They are still using paper. That's the only thing they have. They may have email, but we don't have a shared IT system, you know, that these organizations share information. We don't have an HIE. So making sure that we didn't overcomplicate this process, that if somebody needed to be able to print it, they could print it. And, you know, if the family needed to take it home and discuss it, they could. You know, we implemented during the pandemic something as simple as, you know, a DocuSign electronic signature process, which worked for 80% of our clients, but we have 20%, 20% who don't have smartphones, can't manage it that way. So making sure that the solution we came up with could be utilized in several different ways, both, you know, and several different technologies. And then, you know, the benefits, you know, it's a common form used by all partners. I think, you know, 99% of the folks that DHS, you know, interacts with on a daily basis are using this form. You know, so it's reinforcing that partnership. It's helping the clients understand that, you know, we're a shared system of care. It reduces the number of forms that each client has to sign. And that's huge. You know, those of you who work with healthcare know that, you know, they look at family members as individuals. So if a family needs help, it's, you know, 5 different forms, multiple times. So getting, you know, having that barrier released, you know, addressed, as well as getting the larger conversation in the beginning. So if I need, you know, food assistance today and rental assistance tomorrow and assistance with my electric bill next week, I've already signed all those forms. There's not a delay every time I need to expand that need. And it meets the requirements, you know, of everybody's regulations, which, you know, we were very, very excited we got it to 2 pages.
Amazing, miracle.
It's a complex PDF, but we got it there. You know, as I said earlier, there's no common electronic portal. So, you know, those are the limitations. all of our partners have to maintain copies of those releases in their own client files. There's no single system that addresses all of the community partners. It's not fully aligned with VAWA requirements. So they are one of the, our domestic violence programs are one of the programs that will accept our release, but to share information back, they're doing their own. And it's not, a carte blanche for information sharing. We need informed consent, and we've done a lot of work with our providers around the HIPAA concept, but it's not just a HIPAA concept, around minimum necessary. Just because I have a release to talk to the court system doesn't mean I tell them everything. I tell them the minimum necessary to get the work accomplished, and making sure our clients understand that too, that we're not going to suddenly, okay, you've given us, a release to talk to your probation officer. We're not going to dump their your entire medical record over to them. It's like, what do they need to know? And that's what we share. And that, again, it doesn't mandate information sharing. So if an organization has a more restrictive, risk aversion management protocol, they follow them. We've got the client's permission. This is what they say we can share, and we share it with each other as appropriate. So and I'm going to talk a little bit about the successes, and Michael Darman's going to talk more about the challenges. We've certainly seen improved collaboration and access, especially with the families that were identified that we're doing the work with in Bridges Out of Poverty. It's helped the communication as we come to the table, and remove those barriers, because those consents are obtained in the beginning when folks come in through any front door, and it's immediately shared with everybody as folks go through, through systems. And I also think there's been an improved understanding for clients and for our community partners about what information sharing is appropriate, what information is not, what does consent really mean. So I think we've made a lot of strides there. It's certainly not perfect. Retraining is important as staff come on board, both in our organization and our partner organizations, making sure that they get this grounding in this tool. Michael Darman, you want to talk about some of the challenges?
Sure. I think on the challenge side, one of them is sort of the inverse of what Jan just said. So as Jan mentioned, we had extensive training when we first launched the form for our partners for DHS staff. DHS staff are trained on the form as part of their orientation. But what we found is there's a need for consistent training across all the providers, reinforcement on an ongoing basis, because the alignment drifts over time. Each little program develops its own interpretation, and that may no longer be aligned with the organizational interpretation. Leadership changes, and suddenly somebody no longer wants to accept it. So there is a need for consistent support, almost like a data system. And then on the data system side, we don't have one. So there's no central management platform. People manage these, as Jan said, the same way we use traditional release forms. The reason why we don't have a single platform is there's nothing that all partners can use for all clients. We couldn't have the health clinics and the food banks and us all putting things in the same system. We don't have the security permissions for that. We don't have the infrastructure to support it. Double data entry is a barrier. Each DHS program and each system partner has their own systems. So to ask them to re-enter all their clients into a central system isn't really sustainable. And if only some partners opt in, say DHS and the food bank opt in, but all the clinics and the housing providers opt out, then it has limited utility because staff still have to go through another process with all the other partners. So we haven't found an approach to overcome that challenge at this time. Neither, Jan, any closing thoughts? That was our last slide. We can also show the form itself if you'd be interested.
I think it'd be helpful to show the form if folks haven't seen it, just so you can see. We use the HIPAA guidance for release of information as our basis, but we then expanded it to allow for other programs. So yeah, I think showing it would be helpful. Do you have it up, Michael? I found I can.
Don't leave us in suspense.
All right, here it is. Jan, do you want to walk through?
Sure.
Not seeing it yet. I think you have
Yeah,
to
me
read.
either. I'm still seeing the PowerPoint.
It says to me it's sharing.
Sometimes you need to do a reshare.
Yeah.
I thought I did. Could somebody else share to knock me off and then I'll share again?
Okay. I'm gonna do that right now. Okay, and then let me add you back in as the authorized sharer. There we go.
You need to sign a consent form, Daniel.
That was the problem. Couldn't find myself in my own system.
Right. So, this is our basic form. It starts with the, the typical demographics, and then it walks through, what do folks want to share? Why are we sharing it? It's for, facilitating effective service delivery is the minimum necessary. We are not conditioning services on this sharing of information. And then they can, say everything, or they can be very specific. I want you to share information related to my crisis management needs, but I don't want you to talk about my, my criminal history, or fine, or my, my substance use history. It gives the client the authorization to tell us what we can share and what we can't. And again, the other fields are the things that are required, by HIPAA. Can we exchange or just disclose? How can we share information? We have some clients who aren't comfortable with us sharing anything technologically. You can call somebody, you can send it in writing, but don't put it on the internet. So again, allaying those concerns, and if they put those restrictions on us, we honor them. Why are we sharing the information? How long is it valid? We do ask that this release be updated at least once a year, so that folks can revisit this conversation. And then they can tell us what organizations we can share information with. And we have this grouped by need, folks like us and public schools who provide multiple services, can I only share information, relating to our housing partners, food partners, parks and rec. Then we go to the second page. Here's a whole nother list, folks who can help with, legal issues or the courts, behavioral health. And then we have lots of others. So there are some of our programs who, need to share information consistently. Our developmental disability program has a whole different set of community partners. They list those in the others, and they kind of create their own version of this form. So we wanted to have that field available for those other partners who may not normally exchange information with the entire system of care, but in certain pockets they're there. It's got the required legal language about it being revocable. The person signs it, or their substitute decision maker signs it, depending on what their capacity level is, and if it needed to be interpreted prior to signature, how is that accomplished? We did already create a Spanish version of this form because that's the #1 second language spoken in Arlington after English. But we do have requirements that if somebody speaks a different language, we're following the LEP guidelines, and it's getting interpreted prior to signature.
Hey, Jen, if you don't mind, I just want to ask a quick question. I love the detail on this form. Do you find that as people fill it out, that there are kind of like certain flavors of ice cream that people select? And I'm just curious if you just kind of speak to that a little bit, like where there's clustering, what you're seeing.
Right, sure. So we certainly have folks who are more comfortable sharing, health information because they're used to that. But when you start getting into mental health information, substance use information, criminal justice information, those are things that people are likely to say no to. Why would the food bank need to know whether I have criminal history or not? They don't. So if, we're fine, with honoring that. And oftentimes, when someone's first entering services, they'll be really restricted. You can just share the information related to the benefits that I need. And then they're willing, as they become larger part of the system of care, sharing more information. as they're, as they get, they trust the system and that we're sharing information. We also often will say if somebody's being really restrictive and they only want us to share information with one organization, we do have a single party release, like just fill that one out. Don't do this. If it's, you can only talk to, to Bob at this facility. But yeah, typically, it's the things that are stigmatizing that people are uncomfortable sharing. And honestly, because we are where we are, we have a large military complex here. Some folks are very hesitant to let some of the people know that they are military. They want to protect, not have us, contact their commanding officer. So they'll keep their military history private, at least in the beginning. Things we
I
don't.
don't think we just,
go ahead.
just went blank. We just lost you for a second.
Oh, I'm
So-
sorry. Can you hear me now?
Yeah.
Okay, good. Yeah, we don't ask about specifically about somebody's legal presence in the country. We try very hard to, only divulge that when we need to. And I think that's helped folks who may have issues with legal presence be more comfortable with us sharing information with other organizations, as that's not something we lead with. But it's certainly a challenge and things that people want to keep as, as confidential as possible.
I think the real success of this was getting our own staff to agree to use only one form. We have a lot of sort of either, people who have been here a long time, or people who believe, they're free operators, or they've created their. So getting 700 people to agree to use one form was in and of itself an accomplishment, but getting the safety net nonprofits to agree to use it. And that really, I think, extended a lot of goodwill to in both ways, that they were seen as equal partners to us, and that we were bringing them in on, as opposed to sort of imposing, this is what it is, we created it together. And that really went a long way to establishing trust.
Yeah, the follow-up I was just going to ask, and I just noticed somebody put it in the chat too, is I really appreciate, the layout and the thought that went into this. And if you'd be willing to share it with all of us, I think that'd be awesome. But
yeah, happy to. And if you'd like,
I think Daniel's already posted it somewhere on the network site, right?
Yeah, and we'll make sure that we put a link into it. I don't know if you have this, you sent it to me. I don't know if there's a, yeah, if there's a link. Yeah, we'll scan it, or we'll make sure it's available for everybody to pull down, and we'll actually include it in the, I think we have the opportunity to include it in the consent scan as a resource as well. So as we make those changes over the next day or so, it's fantastic stuff. I think a lot of people would love to see it.
Happy to share.
I
saw
have
somebody in the chat said they've already filled it out to
Yeah.
release everything. Thank you.
I have a question, since you're a county agency. How much cooperation did you get from the state and state agencies that are there in the county?
Well, we manage the state programs in the county. So social services is part of our umbrella. They work for Anita. She tells them what to do. The public health department is part of our agency. So we didn't have that many hiccups. And again, because the state of Virginia had already created something similar, we didn't really run into any hiccups from that perspective.
Great. And the other question I had is, when the client signs this consent and they check off and say, I want to share this information, and let's say it's education records, which you have on there. And you mentioned that some of these agencies have more restrictive sharing. So did they still restrict some of this when, even though the client or participant said, I want it shared? No,
we didn't run into that. Where we run into some of that hesitancy is the minimum necessary. So when it's time to, is it important that I dropped out of high school, or is it important that I have an IEP and what that education plan is? It's what level of detail needs to be shared to get the goal accomplished. And so that's where we've had issues. And we see, there's certainly absolutely nothing wrong with calling the client and saying, hey, I have this release. Did you mean that was okay for me to share this? But no, we really haven't had that issue. It's more in the, our hospital was a challenge. Just say that, getting them to, to understand what minimum necessary was. And why it would be necessary for somebody in the social services program that was approving Medicaid to know what somebody's diagnosis was at the hospital. But it's been more of a, sometimes we have to pick up the phone and have a conversation. The form isn't enough to explain why we need something.
Thank you.
And I think, as Jan mentioned before, there are some niche things that wouldn't be shared with this. So like our domestic violence provider will still need to have people fill out their own form to share information with us because it doesn't meet VAWA. The hospital, I think they said they wouldn't share substance use information because their interpretation of 42 CFR was different for their risk management. So it's not a perfect form, but it improved things greatly for many providers.
No, I'm still intrigued by that comment that you made earlier about people evolving what they're willing to share as they interact with you. I mean, will you comment a little bit more on that? I mean, like, does that take place over months or years? Is it many years? And in general, yeah, it's really interesting.
There's always the caveat of our clients, who truly have a diagnosis of paranoia. That will take years. But oftentimes, there's still a lot of stigma attached to applying for these services. So when I'm walking in the door asking for this service the first time, whether it's because of stigma or because of my culture, I may be very protective of my information because I'm not sure what you're going to do with it. Are you going to tell, my brother who lives down the street what's going on, or is this going to wind up, in a database somewhere that the whole world can Google? So it really is building that level of trust. So people may be hesitant to share things in the beginning, but as they see that, letting my behavioral health case manager talk to the person who's managing my housing grant or my landlord, that I'm getting better services, that my needs are getting addressed, that I'm not getting hassled because my landlord suddenly understands some of my behavioral health challenges, then people are more willing to let us share that information. But, you do have to build trust. And, this form can always be updated. And there's always the instance, it doesn't happen that often, where I get mad at you and I revoke everything. We deal with that now, and, before we went with this. So that does happen rarely as well. But yeah, you're building a relationship with the client and with the family. And they don't know us from Adam usually when they're walking in the door the first time. So they may be a little hesitant to tell us their full history or want us to share that if we need to.
Can you talk about how the different ways that, first of all, outstanding work, really, really great. Great on, especially this leadership, and hopefully we can get this out so other counties can benefit from your leadership on this. Can you talk about how the different organizations have been using, once they have the ability to share the information? Like, obviously there's going to be, some kind of care coordination component or following up on referrals, obviously. The electronic communication, are you able to streamline kind of eligibility across a broader set of programs, or are you able to maybe even within your own organization just take information that they've already applied for this and then fill out another program, as you said you have 100 of them, and reuse it, even if it's just within one organization?
I think it reinforces, we've always been an integrated department, at least in the 18 years that I've worked for the county, but we still had strong silos. So even within our organization, people were uncomfortable with yes, we may share information across the entire department, but they were uncomfortable doing that without some written consent. So this has helped allay that concern. Okay, here's a consent for DHS to share information with DHS. And that's been a constant battle. But Michael Drummond, do you want to talk a little bit about how this has helped the Bridges Out of Poverty work? Because I think that's the place where we've seen it the most without external partners.
Sure. Yes. I mean, one of the things that we've piloted recently has been trying to improve integrated services in a very sort of hands-on, human-centered way. We had case managers identify some of the people who had needs across multiple life domains, housing, food, job, behavioral health, perhaps, who were parents of children and who were interested in working long-term on helping to move their families out of poverty. These families all received a standardized assessment. And then the case manager came and met with a multidisciplinary case review committee each quarter to discuss that family's needs and get linkages to services. So they discussed what the family's goals were, what progress has been since the last meeting, what has worked and what hadn't. And that case review team, which would have representatives from housing, from public benefits, from behavioral health, children's services, housing providers, sometimes legal, depending on the team, would do what they could to meet that family's needs. They might say, okay, instead of saying, go see the people in the employment center, they'd say, go see John on Thursday at 7. I'll tell him you're coming because he can help you with X, Y, Z. So it's something that we've seen. It didn't require any new resources. This required using resources in a new way. And we've seen really surprising outcomes, I think, from it in terms of people stabilizing their basic needs and even started to make progress towards mobility. And it sort of led to something that we're working on now, which is an unconditional cash assistance pilot that sort of is the next level from that. But I think, Matt, you were also asking about how our data exchange is. And I think this release is necessary but not sufficient for data exchange, right? Like we have this in place and that allows us to talk the way we've always talked, but to build in that additional layer of actually being able to take that information and automatically exchange it across information systems, we're not there right now. We have systems that we use that are built by the state or by the federal government that we don't have any control over, and there's not really a way of extracting data or importing data into that in a way that would be useful. We have systems that we build ourselves or license ourselves that have limited capacity. We have a data warehouse, but there's a limit to what it can do. So we have a lot of the building blocks, but we're not at the point yet of being able to integrate them seamlessly.
Got it.
That's what Daniel's helping us with.
Well,
Interoptima.
This is an amazing group of people on this call and others who join here who have a lot of experience with sort of that integration interoperability stuff, which is awesome. I wanted to make that introduction to you. There are other questions. I have a number of questions, but I want to hear from other folks if there's other folks with questions out there, because this is so extremely interesting stuff. Anyone? So one question is just from everything we've been hearing, and Adam alluded to it earlier, and we know the foundation community as well around is totally focused on equity these days, longer than these days, but more recently these days. How do you establish that trust? Jan, it almost sounds like it's, somebody walks in the door and they're enveloped in sort of in the organization in a way. Before you get to what information you're going to share, you have to do some triage, right? I mean, they're in for food, but they may have 2 or 10 other things. So help me understand a little bit what that sort of process looks like.
I think it varies what door they walk into, but or virtually or in person. But it's having that personal greeting. I'm going to meet with a person, whether it's through this kind of means or in person. How did I get referred? Our community partners are often in the person's community and doing that referral, so they're building that bridge. We have staff who work in the community as well. But yeah, I don't think I don't think that has anything to do with this forum. I just honestly think it's how we do our work. Is we have to meet the person where they are, respect them, try to get them through their immediate crisis, and then talk about what the next issue is. It's usually what they're walking in the door for the first time. again, there are lots of underlying issues. Let's get your food need met. Do you have, some employment needs, housing needs? Asking those questions, but you've got to meet the person where they are and try to get that need met first. Anita, what would you say there?
Well, 75 to 80% of our customers come through one door. It's called the Customer Service Center. We have it's kind of like our social services. We call it economic independence, but it has housing, food, employment, crisis management, public assistance, everything, TANF, SNAP, food. And we have a robust triage system in the front, both phone and in person. The other 20% of our customers are either in a specialty population, like they're either a senior, an older adult, a child, a person with serious mental illness, a person with developmental disabilities. And they have different doors because within their doors for their respective populations, they have the same kinds of social safety net benefits, but it's all wrapped into their population, if that makes any sense. It's like we have one main door and then all these little ancillary doors. Does that make sense?
Sure.
Am I
Yeah.
describing that
Yeah.
right, Michael Dharma?
Yep.
Yeah, and I would say too, the training and oversight that our customer service representatives receive to provide this integrated service is amazing. Our customer service center supervisor has, she trains people for, I think it's a whole month, maybe more than a month. She listens in on a huge percentage of their calls. She gives them feedback. And her objective is whatever that person's need is, they're going to meet it. Even if it's that they need to be connected with something in Arlington, Texas, not Arlington, Virginia, we'll try to direct them to the right resource. So I think it's that philosophy and oversight and training that makes this possible.
Daniel, if I may add, I think that's excellent what you're doing. And when we did this in a program many years ago, one of the things we did is we had all the providers go through training to talk to them about what we were doing and all those resources and what the form meant and the consent. So we did a lot of intensive training with those community agencies to also get them on board with the same philosophy.
Mhm, mhm. That's amazing. So that already establishes the trust, starts to establish trust at a very early encounter with people walking in the door.
And it sounds like though that people are recognizing that they have needs, right? And they're engaging with you for services. So you're not ambushing them and saying, oh, you need something, let me help you. I mean, they're predisposed, I would say, to you're helping them.
Often they're coming in for one thing and we're we get that need met, again, meet them where they are, and then starting the conversation about other, so they may not understand fully what they need. I need help with a medical bill, so I'm coming in with that. And, we get that need met, but then, can we help you apply for Medicaid? Do you know about the healthcare exchange? It's like trying to, look at them holistically after that initial need met.
And do you guys have
The
any
goal is to help them
statistics?
have a sustainable solution, right? Not needing crisis assistance every 3 months, but what can we do to connect you to resources that will meet your need long term?
Yeah, I was going to ask something just like that. Do you have multiple encounters with them, or is it mostly one-offs?
I think it varies. There are programs like our public health program, and they're bringing your child in for immunization. You get that done and we're done. But in our other safety net programs, absolutely, we have multiple encounters.
Mary Sarah has a point in the chat here about people may not even know what they're eligible for, right? And making them understand, helping them understand that would be sure big.
And that's honestly a place where this form has helped when you're going through the the list of community resources. Did you know these programs exist? Let's talk about them. So it does having everybody on a piece of paper does kind of help show folks what are available to support them.
And it's a challenge even for staff. That's part of why the customer service representative training is so intense, because they need to know 100 DHS programs intimately. They need to know the community programs. It takes a while to build that expertise. So we do what we can to help clients navigate that system.
Are any of the referral programs in the county, like, Unite Us or Aunt Bertha or whoever they are now these days? Do you guys use any of those for referral or closed loop referral at all? So you kind of do that.
Not at the moment. We had tried during Bridges of Poverty to make our own little homegrown system, and the logistical challenges were too much to sustain that. And then COVID happened. But I've definitely been paying attention to some of these things as they've developed. And when the time is right, I'd be interested in exploring it again. But I think those challenges that we mentioned during the presentation of, we don't want to have to double a data entry for everybody. And if not everyone is using it, then it becomes less useful. Those are still barriers.
Mhm.
Can you guys comment a little bit about who the non-adopters are?
I don't think there's a systematic pattern. I think it's more that there's always early adopters and late adopters. So when we tried to do a electronic referral system, we had some folks that were very enthusiastic and were heavy users. We had some that continued using it. We had some that dropped off. We had some that weren't interested. So we found that when we had such varied participation, it had less value because you can use it to refer to the free clinic, but not to neighborhood health. So you can't just use it to refer to all the clinics available, something along those lines. So it needs maybe more planning prior to implementation than we put into it at that stage.
So one last question. I know we've now officially moved into overtime here, as I like to say. So folks who need to jump, by all means, but we'll go on for just a couple more minutes here. I'm thinking about, a lot of the work we've just been completed, and we just completed, and that's in that consent report that you've seen some information about. Automating this, there's a lot of discussion around computable consent. And I'm curious because you've got a lot of paper you're managing, and I'd be fascinated to sort of know what the logistical sort of business process looks like to manage that, make sure the consents are they're accurate, they've been updated, they haven't expired. How you manage that on a sort of a card file almost, right? Which I imagine there's something like that that's happening.
We have,
Yeah.
We're working on interoperability even within DHS, but we are mandated to use state systems for some programs. We have some of our own internal systems, and each one has some sort of a document scanning attachment that these things are scanned. Our public health program, which is state funded, which is still virtually on paper. The state has not moved to anything electronic in public health.
Waiting to leapfrog.
Yeah, and some of our business partners are also still completely on paper. So we're managing it the way we did before we had the integrated release, honestly. So when it's there, when folks are ready to exchange information, they look it up to see if the form is there, it's current, it's signed. Our behavioral health software does have a way to track it, but otherwise it's pretty well a manual process.
Yeah. So maybe some parting thoughts about this idea of applying technology. I mean, it's. And I'm also thinking, of course, of much larger, thinking about Paulu's and the Bronx, or other folks who are in larger systems, and take sort of moving from a very clear sort of human sort of design perspective of I can hold it in my hand, I know what I'm checking, to a more, I'll use the word computable, that seems to be sort of the term of art these days. I'm really trepidatious about that because not everything translates well technologically, or not certainly intentional. I don't know if I'm sure you've thought about that a bit, but as you think about moving or advice to other larger organizations, or as you guys move to a more automated interoperable system at some point, what kind of considerations you have? Is it going to be helpful? Is it going to be hurtful? Is it going to be redundant? Anything that comes to mind on that?
Well, we have been able to build it electronically in some of our systems. So some of them are checkboxes that you fill out in the system. I think some can even do electronic signature. So the technology piece isn't the barrier. Where we have systems that can accommodate that kind of electronic release form, they're also accommodating all other electronic forms. So the staff and the customers are used to that interface, and that's not a barrier. I think the big problems are some of the things that we talked about before, right? One is meeting our partners where they are. I think even in a large system, you will have some nonprofits or some other people you want to exchange information with who aren't going to have a electronic health record or a system that plays well with a central information exchange. So how do we accommodate the process for those partners? How do we make it as easy as possible for staff so that we're not asking them to enter their clients into 2 different systems, managing referrals in 2 different ways. We're not adding a lot to plates that are already full. And of course, if you have a central system, who secures it, who administers it, who trains people on it, like where do you get the resources and who has the security authority? I think those are all things that come to mind, as well as just stakeholder engagement. One of the things I think we'd mentioned earlier in our process was we had been thinking about a multi-party release for a long time, but not until we started Bridges Without Poverty did we have sort of the communal will to get it done, because people clearly saw how connected to their ambition to provide integrated services to our clients that we all served. So making sure that whatever the solution is, it aligns with the community's priorities and they're interested in the goal, not just the form.
I also think that and this particularly became apparent during coronavirus, as we started to identify who wasn't getting vaccinated. You know, there's the state, the county government and the other sort of local government entities. Then there's sort of the traditional safety net nonprofits, but there are whole levels of other networks of partners that you need. Doesn't matter if you have the best, integrated network and technology. You need a different kind of engagement strategy with people, especially given distrust of government, and rightly so. You're looking at our history, immigration policies, language barriers, cultural differences. So, you need to basically go back to the grassroots to reach those who are really most vulnerable.
Mm-hmm. Well,
So,
any last question before we wrap here? I want to thank you so much for the amazing work that you're doing and your willingness to share it broadly. I think there's certainly a lot of interest from this group, and we hope to be able to proselytize far and wide, and certainly invite you as we move into the trying to move these kind of conversations forward on a national basis, to invite you into those conversations. We expect to be doing more of that hopefully later this year around consent and some of the integrated care for kids sites and maybe other places. Bringing your wisdom and knowledge will be just fantastic. And again, feedback on the documentation and ideas on how we can improve it and contribute to it. We see it as an ongoing effort. So with that, I want to just say a few words. I want to actually ask Ed Daniels to just say a few words on next week's event. And you're all invited to come to it if it excites you and interests you, or if you're on your mailing list, we'll continue to torture your email boxes. Ed?
Yes, well, thank you again to our presenters. I concur with what you said, Daniel. It's a very interesting presentation, and we would really invite ongoing dialogue and look forward to that. Regarding next week, of course, I work most of the time with Mary Kratz at the Interoperability Institute, and we work on our e-consent collaborative, which has been focused mostly in advanced directives. But fortunately, the Interoperability Institute has created their interop community and a technological sandbox called MELD, which allows the testing of systems and proving of interoperability among different applications, including with EHR's medical record systems. And so next week, we're going to be doing a demo of the MELD sandbox and showing what its capabilities are and how it can be used in order to test interoperability, establish workflows, and bring in multiple vendors and help with the integration of such challenging situations as we were just presented with today by Arlington County. So anyway, I look forward to that presentation. We're going to make it nice and concise, but I promise it'll be interesting to pretty much everyone. So thank you. And through speaking with Daniel, we're trying to work on ways to make this available to this organization here, Project Unify. So I think it's particularly relevant, not just an academic exercise.
Thanks, Ed. Yeah, it should be fascinating and also very applicable as we go forward on this stuff. So I think that wraps for the day. Anybody who is not on the mailing list and wants to get on there, got a couple notes here. Just make sure you connect with Amanda, and she'll keep you up to date on what's happening out there. And with that, I think we're done. So thanks everyone from Arlington for taking the time to do this. And we'll see you again next week, everyone. Have a great weekend. Sorry, we're not at the weekend yet. Have a great rest of the week.
Seems that way.
Yeah,
Thank you.
exactly.
Thanks.
Thanks all.
Wishful
Bye-bye.
thinking. Have a good week, everybody.